He's a well-known personality, as you all know, in the field of telemedicine. He has been working since the inception in Nepal. He's none other than Dr. Uday Koirala, a senior consultant surgeon and also head of department at Kathmandu Model Hospital and associate professor of surgery at National Academy of Medical Sciences. After completing his college, he completed his MBBS from Beijing University. And he came back to Nepal and started working in mission hospitals to serve the rural people living in the rural and remote areas of Nepal. Then he joined as a lecturer at Kathmandu Medical College in 2004. And finally, he came to work with us at Kathmandu Model Hospital, and he has been with us for a long time now. He's working as Deputy Director in the Center of Rural Healthcare and Telemedicine, Public Health Concern Trust, Nepal. Today, he'll be talking about training and curriculum in telemedicine. The need of curriculum and training in telemedicine is increasing more and more, especially during the pandemic. Even though the use of telemedicine is overwhelming all over the world, in Nepal, it is not as much as we expected. So let us hear from him in detail about training and curriculum in Nepal, in rural countries. Thank you.
Thank you, Dr. Pooja. First, I would like to have a song. So, Dr. Shreyas from Nagi Rural Health, please introduce yourself.
Hello everyone, I am Dr. Shreyas. I have been working here in Nagi Rural. It is a rural village in Magdi, and I am here since 2 weeks, and I am under the Fate Nepal Trust.
Thank you. Dr. Suvas from Mediflow.
Good morning. I'm Dr. Subhas Pakrel, an innovation-loving doctor, more into innovation field and working as a gap filler through different domains. Thank you.
Thank you. Shintaro, Ida.
Hello, this is Shintaro from Kyushu University Hospital, Temdet.
Thank you. Ibrahim Ghani from Sankara.
Yeah, this is Ibrahim Ghani from Shankar Nethralaya Hospital. I am taking care of IT infrastructure and telemedicine in the Shankar Nethralaya Hospital, Chennai, India.
Thank you. Dr. Rajkumar from Gauri Shankar.
Namaskar. Good morning, everybody. Nice to see you all here. I'm Dr. Rajkumar Dangal, working as a MBGP, general practitioner in Dolakha Hospital, a rural health center in Dolakha Hospital, Dolakha district. Nice to see you all here again.
Thank you. Nirajan Rajuli from NREN.
Hello everyone, I am Nirajan Purajuli. I am a network engineer of Nepal Research and Education Network. I am supporting technical for rural healthcare session. Thank you.
Thank you. Rojan from Model Hospital.
Hello everyone, I'm Rojan Sai from Kathmandu Model Hospital, and I'm the engineer. Nice to see you all. Thank you.
Thank you. Idris Sulaiman here. Dr. Idris has also joined. Dr. Idris?
Yes, hello, good morning.
Good morning. Can you please introduce yourself?
Hello, yes, my name is Idris Sulaiman. I'm from the e-research support working group for Southeast Asia. However, of course, we are keen to work with other partners from around the region. And I'm very happy to be part of the medical rural healthcare session. Thank you.
Thank you. Thank you, Dr. Idris. So I will be starting the presentation. So as we all know, this telemedicine we have been practicing for a long time, and now we are just studying why this telemedicine is not being that much practiced in our part of the world. So when I looked at some literatures, I found that this training and curriculum in telemedicine is one of the important part to develop telemedicine. We all know this telemedicine, it is spoken a lot, it is advertised a lot. We see many inaugurations in telemedicine centers. There are news about telemedicine, and they are also financed a lot, but still it is used very little. And most of the part we see equipments and they are left unused. Many infrastructure is developed, but they are left unused, and most of the equipments are just kept in showcase. So I wanted to ask myself, why even with the investment that is not being used that much, so have we focused more on infrastructure? Are human unsatisfied somewhere? Should we talk about human factor? Should we talk about training? Should we talk about curriculum? And also about the reimbursement for the people who are working in telemedicine? So the problem I saw was, despite the growing acceptance in the use of telemedicine, there is no widely recognized gold standard or curriculum of telemedicine training for healthcare workers in many countries. And there are very limited or no content regarding telemedicine which are included in undergraduate or postgraduate courses for medical students. Now there are some topics which are taught in undergraduate or postgraduate courses, but they are not meant for the practical use. For theoretical sharing, there are some subjects, some courses that are designed, but I think we should more focus on the practical issues of using telemedicine. Healthcare workers not only should have basic idea of technology, because most of the time we just get frustrated when technology doesn't work, when there is even a small problem. So they also need to learn the various clinical uses of telemedicine. We don't know how to use technology. We don't know how to use the telemedicine clinically. So we also need to understand the clinical and organizational barriers of the successful utilization of telemedicine. So we should know how to develop telemedicine against these barriers. So what I found is telemedicine curriculum should be designed according to the need of the users. So we should focus on the user sides, not on the engineering sides or the manufacturing sides, but we should manufacture according to the need of the users. So, and at the same time, we should address the communication and automation tools available to the healthcare system. It is widely accepted that physicians and other healthcare professionals will only begin to use telemedicine successfully once they have had an opportunity to learn how to implement this technology. So there should be training program. It can be short training program for the telemedicine users, telemedicine facilitators, technicians, engineers, other healthcare workers. So this would include an organized repository of resources representing foundational topics and best practices in telemedicine. And curriculum should be designed to help healthcare personnel to practically use telemedicine in the field. So according to the need of the field, content should help all level of healthcare workers, like community level healthcare workers, students, residents, faculty, to obtain the skills needed to deliver telemedicine care in their practices. And ultimately, patients should start believing in telemedicine, and they should be comfortable using telemedicine. Curriculum should be developed to specifically address need in rural and other underserved areas. So we all know this knowledge, skills, and attitude in curriculum training aspects. So important aspects in telemedicine, I think, for the knowledge is basic computer skills, basic computer knowledge, internet knowledge, and also the environment, like the environment of the telemedicine room, telemedicine hall, equipments, lighting, designing. So these things are also very important. And psychology of the patient other side, because you are not physically in touch with the patient, so you should read the psychology of the patient to communicate. There are other issues like legal and ethical issues, privacy maintaining, setting of the private environment, especially for the female patients, data security, encryption, and financial and administrative issues. For the skills, computer skills, internet skills, email writing, store and forward, browsing, communication skills, used apps, knowledge and skills about the apps, video calls and conferencing, photo editing, video editing. These are the skills that are needed. About the environment, for the attitude of the personnel who are using telemedicine is designing of the room, comforting the patient, communication, how to communicate with the patient, how to communicate with the patient during consultation, during referral, and also about the spoken language, telelanguage, telemedicine language, and language of different accent. So these things, I think we have to train, we have to acquire. Training strategies can be like information session, didactic session, lectures, practical session, and workshop like hands-on, online, and also demonstrations. And there are certain specialties in telemedicine which are pretty developed, like telepsychiatry, teledermatology, teleradiology, teleultrasonography, ophthalmology, telepathology, telesurgery, telehome care, teleeducation. So these things will need special attention when the curriculum is formed. And also like for continued professional development of the clinicians or other technicians, continued medical education for clinicians through telemedicine. These also can have a structured training program or curriculum. So actually my conclusion is training and curriculum are needed, and we should start structured training and structured curriculum programs in telemedicine. These are my references. Thank you.
Thank you so much, Dr. Uday, for a wonderful presentation. It is indeed time for us, especially in the rural areas, rural countries, to start pushing on the basic training and curriculum in the field of telemedicine. Next, we have Dr. Fadila Mathar.
Dr. Fadila is here.
Would you like to introduce yourself?
Yes, thank you very much. Let me just share my screen first.
Let me start with a short introduction about Dr. Fadila. Dr. Fadila has a doctoral degree in strategic management, Faculty of Economics and Business from University of Indonesia. She has worked as a lecturer in Sarif Hidayatullah State Islamic University. She has been a coordinator of National ICT Training Center, Ministry of Communication and Information Technology, Indonesia. After that, she has worked as a division head of planning and evaluation of R&D Research Agency, Ministry of Communication and Information Technology, Republic of Indonesia. And presently, she is working as a Director of Resources and Administration of Telecommunication and Information Accessibility Agency, Ministry of Communication and Information Technology, Republic of Indonesia. It is indeed a pleasure to have you, ma'am, with us. And today, in this session, she'll be talking about connecting the unconnected healthcare facilities in the largest archipelagic country. Now I would hand over to you, Dr. Fadila.
Okay, thank you very much, ma'am, and thank you for your kind introduction. As the moderator already introduced me, I'm now Director of Resources and Administration under Telecommunication Agency of Ministry of ICT Government of Indonesia. And Bhakti is an entity focusing on the solution of inclusive telecommunication access in Indonesia. And the reason why I have a chance to speak here is probably because of my involvement of making healthcare facilities like hospitals and public health centers go online, especially in rural areas. Bhakti have to build infrastructure, especially in those frontier, outermost, and least developed regions. A good place to start is to give you a brief portrait of Indonesia, the world's fourth most populous nation with 267 million inhabitants. Indonesia are separated by seas and clustered on more than 17,500 islands. Ethnically, the country is highly diverse with over 1,300 ethnic and 600 local languages, but only 13 have more than 1 million speakers. 40% of Indonesian population live in rural areas. Indonesia have more than 75,000 villages, and to control the maturity of the villages, government set Village Development Index, which is formed by 5 dimensions, where health is one of the fundamental basic services. Baseline will be helpful to review where Indonesia are now. The Bloomberg Global Health, for example, takes into account for health risks such as smoking, high blood pressure, and obesity, life expectancy, malnutrition, and causes of death to rank 163 of the healthiest and unhealthiest economies in the world. In 2019, Indonesia's ranking is 102. And after doing some benchmark from other countries' best practices, we target to reach at least top 80 in 2024 by leveraging digital to improve prevention and detection of lifestyle disease and to strengthening physical infrastructure and equip healthcare personnel with digital skills. Build secure and reliable connectivity and infrastructure with high quality of service is the direction we aim at. Indonesia has 4 main initiatives of infrastructure provision. The first one is to expand 4G coverage with national fiber optic broadband. Secondly is to increase access by ensuring that 4G in villages will be equipped with BTS or last mile deployment. The next one is to maximize digital dividend by ensuring analog switch off by 2022, and it's also the precondition to 5G commencement. And the last one is to achieve comprehensive coverage by enhancing satellite network capacity. I need again to highlight that Indonesia have more than 17,000 islands, so rely on fiber optic only will be very, very costly and impractical. As an effort to support and accelerate COVID-19 recovery, the Ministry of ICT expedite the internet access in the remaining 3,000 healthcare facilities by the last quarter of 2020, and we succeeded. So last December marked the great achievement when all healthcare facilities in Indonesia finally go online. More than 13,000 healthcare facilities, even in very remote islands with least population, now connected to the internet. The expanding provision of telehealth services and integration of electronic medical records continue to drive forward digitization in the healthcare space, and ICT spending in the sector also grew significantly. Collaboration between public and private organizations also look to support this enforced digital transformation. For example, partnership between some startups in Indonesia and the Ministry of Health resulted in the launch of free online medical consultation services for Indonesian citizens with COVID-19 symptoms. This telehealth service helped ensure that people with reported symptoms were able to access instant medical advice, integrating the services of over 20,000 doctors and catering for about 2 million users across Indonesia. Now we are finalizing the Digital Indonesia Roadmap, where digital health development focus on digital health records, telehealth, and the use of big data for disease management. And after completing the basic infrastructure for healthcare facilities, 6 initiatives will be prioritized by 2024. We start with the extension of the healthcare reach through telehealth program. Indonesia is facing shortage in medical practitioners. There are only 3 doctors for every 10,000 Indonesians, which is more than 10 times below the OECD average. COVID-19 has also accelerated demand for telehealth as more patients feel comfortable seeking out medical services and seeing their doctors online. Use of the telehealth can amplify the capacity of clinicians and healthcare networks, connecting patients to doctor for non-urgent immediate care, as well as follow-up care with specialists and primary physicians. Secondly is the implementation of electronic pharmacy logistics system. With over than 6,000 inhabited islands forming the country of Indonesia, making sure that drugs are where they are needed, when they are needed is a major challenge. The third initiative is to implement national health records. It is common for patients to visit multiple healthcare providers, and Indonesia is still largely relying on manual health record, and as a result, patient health records are spread across different healthcare providers. Both patient and healthcare providers don't have a holistic picture of patient healthcare history, which is necessary for healthcare professionals to deliver safer, better, faster, and more personalized care. The fourth initiative is to develop medtech ecosystem and hub. Indonesia identify opportunity lost from outbound medical tourism due to a lack of trust in the local system and infrastructure, worsened by unevenly health services distribution across geographies. So the development of local health industry is crucial to overcome this problem. And the last 2 initiatives are to apply analytics in healthcare, for example, for the disease management, and expand contract tracing for access management. Some digital health initiatives have been accelerated with COVID-19, with some longer-term strategic initiative under progress. Key development on rural healthcare focus on digital health records, telehealth, and the use of big data. And now government requires hospital to integrate with healthcare mobile application, as well as enabling data aggregation and analytics for disease management and policy making. Government has a vital role as a catalyst of providing the framework for technological capabilities that are fundamental to driving toward digital development. There are a number of key technologies in health sector which need to support the provide a conducive environment for wider digital opportunity. Finally, transaction-heavy sectors such as digital health should address cybersecurity risk and fraud in order to enhance their customer experience and cybersecurity resilience. Data sharing and protection in telemedicine and internet ethical use is essential, very fundamental to ensure the digitization of health sectors. This issue will be more elaborated by my colleague, Dr. Idris Soleiman. Thank you. I now offer the session to
Okay, thank you. Yeah. So, can you please stop sharing? Yeah, thank you. Thank you, Fadila, for a nice presentation. So, there are so many platforms for this telemedicine and telehealth, and it is interconnected, I think, with electronic records in a hospital records and medical records, digitalizing the nation, digitalizing the other parts of the country. So it comes hand in hand. So thank you very much. Are there any questions to Dr. Fadila?
Can
you please mute? Kamson, can you please mute? Okay, thank you. Is there any question to Dr. Fadila? Okay, so next will be Dr. Idris F. Sulaiman. He is engaged in engagement and outreach coordinator for Southeast Asia engagement e-research support group. It is an Australian initiative started by a number of individuals drawn from Australian universities and research institutes. Prior to this, he worked as the ASEAN researcher on the Enhanced Regional EU-ASEAN Dialogue Instrument E-Ready project, which is a development cooperation program funded by the EU to conduct the mapping of ASEAN high-performance computing capacity, their related research, infrastructures, and policy orientations. Idris has a diverse background, having worked in research, consulting, and teaching in information technology, data management and policy, the energy efficiency of data centers and buildings, organization maturity, modeling, and business development. He has worked in academia, government, and the private enterprises in Australia, Ethiopia, Indonesia, Japan, and Korea. He has a PhD in economics of technology from the Australian National University, Canberra. So, Dr. Idris, please, would you start your presentation?
Thank you very much, Dr. Udaya. Good morning, good afternoon, good evening to all the participants. Shall I share my screen now? Can you see my screen now?
Yes. Yes.
Thank you so much. Yes, I very much thank you and the committee of the Rural Health Care session for allowing me to participate in this wonderful meetup of various very active players in or stakeholders in the rural health care landscape. And as Dr. Fadila was just referring to, I will take on a little bit further my on the topic of cybersecurity, related to cybersecurity, but also bearing in mind what you have just said before, Dr. Udaya, that I'm taking it from a user's perspective. Actually, before I go and do that, I am also providing a perspective from the coordinating role that I'm currently in, and that is to provide an overview of some of the events that we've had. So with the title Telemedicine, Data Sharing, Internet Ethical Use, this is a very, very complex field, and indeed it should be business for everybody. So just before I go further, I just wanted to provide an overview of what our group is about. We aim to address inequities in medical and research capability and capacity by leveraging opportunities with Australasian research infrastructure providers and the wider research community. Now, the term Australasian really covers Australia, New Zealand, and the South Pacific. For people who may not know that term. We also participate in events. We largely participate in events and organize upskilling training sessions in the areas of research infrastructure, innovative software development, and data sharing capabilities. And these are some, I've listed in the presentation some of the events that we've attended, which is the ARO, or the Australasian E-Research Organization's E-Research Conference, the C3DIS, which is another ARO event, which is computational, conference for, collaborative conference for computational data intensive sciences. And then also we've attended the activity of the Indonesian Medical Education Research Institute based at the University of Indonesia. Last but not least, also at this event, Data Science Exchange coordinated by the Perdana University in Malaysia. So today, I will be very briefly talking about 4 topics, or 3 topics really, but with the background in mind that telemedicine, as everybody knows, is growing rapidly. And I very much appreciate participating in the previous rural healthcare session where there were many other presenters, and one of the points I remember was what Dr. Udaya, you mentioned, that there is such an unprecedented rate of take-up that whilst a few years ago it was very difficult to come up with application for funding and so on regarding to telemedicine, now telemedicine seems to be front and center of a lot of the discussions. So I'm just wanting to allude to a study that has been done by the APAC Telemedicine Market Group, and that suggested that the market in the Asia Pacific region will be tripling in 5 years, and that's only what economists have been able to estimate. I think the reality could be even bigger than that. So there's no doubt from in many minds that this is a very, very important topic. However, one of the main areas which we will look into is this question of cybersecurity and information security. And the way I'm going to do that is by looking at the 3 previous activities that we've done and the works of colleagues. The first one is the Research Data Alliance COVID-19 Working Group. They produced the guidelines and recommendation on data sharing. Another one is work on ASEAN data protection and data privacy. Last but not least, I'm going to talk about the recent calls by very eminent academics, including the recent call by Professor Jun Murai about at the opening keynote address on the term on bringing attention to the internet ethical use. So that's why I use this term internet ethical use to cover all the other, the whole areas of data protection, data privacy, and which is all part and parcel of data sharing. So first and foremost, I like to highlight this work that has been done by the Research Data Alliance, which is an international body of researchers. Everybody is welcome to join. It's free to join for everyone. And it has been very active, mainly in the Northern Hemisphere. However, last year, they've had a conference, they organized a conference in Melbourne, Australia. So I was looking forward to attend that, but lo and behold, COVID struck and the event was canceled, but instead there was an online event. But as a result of that online event, there was a flurry of activities which involved over 600 researchers that have produced this guideline and recommendations for data sharing. And the lead person from the Research Data Alliance is Dr. Stephanie Kiffers. However, there's also heads of each of the subgroups that have been created in order to bring about this guideline. So we have eight groups: clinical, omics, epidemiology, social sciences, and then there are 4 other groups that are cross-sectoral and that are touching issues to do with community, indigenous data guidelines. As you might know, in Australia, we have indigenous people, the First Nations, and also another cross-sectoral area or working group on research software, and last but not least on legal and ethical considerations. For everyone who is interested, the working groups are still quite active, and what is happening is that the working group is planning to transition to become a more general epidemiology working group. The main barrier sometimes for people to attend is the actual hours, because people have very different time zones when you involve everybody around the world. But sometimes this is where we need to work more together with people who are within our time zones. And so I think perhaps there could be other activities along this line that could be generated around the same time zones. Last but not least, the RDA has the infectious disease community, which is another working group. So RDA has over 10,000 researchers involved and over 90 working groups and interest groups. So it's a fairly large group. However, I recommend everyone to have a look at this. It doesn't matter whether you're still a student or whether you're already mid-career or early career researchers. It's a very, very worthwhile organization to become involved with, particularly if you are concerned with some of these topics. So at the regional level, I also would like to draw your attention to the work on data protection and data privacy that has been going on. And at one of our events recently with Perdana University, the Data Science Exchange conference, we had Dr. Emmanuel Layana from the Philippines, who outlined the details of the work that's been done by the ASEAN privacy on ASEAN privacy activities, and this is mainly under the ASEAN Digital Ministers. And this is the group of ministers and the senior officials who were previously known as Telecommunications Ministers Working Group. If people would like to read more about what they've been doing, you can look at this ASEAN Privacy Forum website. The situation in the region, as many of you can testify, is that there's a mixed picture. Different countries have adopted data protection, data privacy laws. I believe within ASEAN, there are currently 4 ASEAN members who already have that, and that's Malaysia, Philippines, Singapore, and Thailand. But Indonesia is in process of formulating this. I've been informed by my colleagues from Indonesia, and hopefully maybe sometime in the near future that this will be also in place in Indonesia. However, this is one of the points that I've shown here are some of the discussion points that we've had in the discussion forum, was that there is another ASEAN group, which is called the ASEAN Ministerial Council on Science, Technology, and Innovation. COSTI is the initials. Now, they have been the one who actually been active in the infrastructure side more, like providing the support on high performance computing. However, I think because of the cross-sectional nature of data protection, data privacy, I think different ministerial groups could be involved. And this is some of the, that's one of the resolutions that we was put forward in our previous meeting. Next, just going to come back to what was discussed at the opening keynote by Professor Jun Murai. And that was very interesting also because like what Dr. Fadila mentioned, he mentioned about the increasing use of satellite technology, and which mean that it will be reaching out for more and more regional hospitals and regional health community facilities. So the question of data protection or ethical internet use is becoming more and more important. If people want to have a good introduction, they can look at some of these ethical issues that have been raised by some of these authors that I've been following, including Dr. Timnit Gebru and also Professor Ron Diebert from Canada. There are good places to start on some of the very complicated issues. However, even as users, I think we need to know, because awareness is key to everything. There are also very, very important work that's been done at the World Economic Forum. And this is around the ethical principles for digital media and technology design for the new normal. This covers, social media, all kinds of aspects of what social media codes should be. And also generally more general data. However, it's really probably important to look at medical and genomic data as a special category. And this actually was also raised by Dr. Emmanuel Layana, he suggested that there should be a special attention being given to medical and genomic data because of the sensitive nature of these types of data. In summing up, I can say that whilst the picture is mixed internationally and at the regional level as well as at national levels, I think people, there's a growing awareness, and therefore various frameworks have been developed and legislated. Of course, the key outcome that everybody is hoping to achieve is to have a situation where diagnostics, treatments, all kinds of practices related to telemedicine can be better trusted. And of course, all depends on greater access and greater adaptation to the needs of particular countries. So there needs to be a kind of close attention being paid to the low and middle income countries because there are differences in conditions. Not everybody's got 4G, not everybody even got 3G in some cases. So all of these needs to be taken into account. Of course, the nagging question is that, are these frameworks being developed fast enough? And like in other technology issues, would leapfrogging be possible? So I leave that those questions to you. And thank you again, once again, for your for allowing me to be part of this wonderful forum. Thank you very much, Dr. Udaya.
Thank you, Dr. Idris. So we are running out of time. So I think we will continue with the presentation, and then we'll have a discussion at the end. So next, I would like to welcome Dr. Subhas Packrell. Dr. Packrell has been contributing through a unique model of integrating healthcare informatics, innovation, insurance, support, and policy debate so as to make health sector of the country more public-centered and patient-centered. As the founder of Health Concern, he has pioneered the system of providers' information along with a mobile app for doctors' appointment, thus by helping people in making their treatment easy, effective, and economic. Likewise, Dr. Packrell's role as technical evaluator of insurer and third-party payer has significantly supported in the growth of health insurance practice in the country. With a tagline of "Time doesn't move with us, it's us who should move with time." So currently he is the Meditech director in the MediFlow with multiple roles like bringing innovation, research requirement, and mixing these with the ground reality of Nepal and international practices in order to bring a practical amalgamation. His concept of child development tracking system is being adopted by national and international stakeholders. In the capacity of medical editor of Swasthya Khabar, #1 health-specific magazine and online portal, Dr. Packrell has boosted the trend of health policy dialogue and roundtable discussion. So I would like to invite Dr. Subhas Packrell. Dr. Subhas.
Thank you. Greetings and namaste to everyone. Let me share my slides here. First disclaimer, there is no conflict of interest and commercial interest in this presentation. I've been using this as a solution or concept only. Okay. This is a complete package of solution that addresses a healthcare ecosystem or patient cycle. Patient is the center of all domains of healthcare. We all know that. There is ministry because patients and diseases are there. Doctors are there because of the existence of patient or disease. There are insurance. There are multiple stakeholders. So with this note, any desktop-based software cannot address the patient cycle. That's our understanding. Rather, web-based technology with secured mechanism that the banking system is using, that the government is using, only can address the healthcare ecosystem or patient cycle. It's like my tagline, time doesn't move with us, it's us who should move with time. Of course, new technology means new features, new solution, and new advantages. Now we can respect the bigger television in the before days, but we cannot adapt it now in this time. Okay, Mediflow, it's not only a software, it's a system and services, because it has got multiple modules as a package. First, healthcare management information system. Out of that, hospital management system includes all the packages we need, like counter, registration, pharmacy, laboratory, that addresses the administration and management part. In healthcare, we all know the management part consists of around 20% weightage only. The next 80% is occupied by the clinical side. So we have topped up the product with electronic medical record, and it's highly research based. We have, of course, addressed thinking globally, acting locally while creating this electronic medical record. It's been designed in a customized way with a clean field, with a time consumption calculation model, so that it can lessen the time consumption of patient, professionals, and even the administration side. And it has got all the implications like second opinion, organized referral, telemedicine, etc. Okay, and it has been connected with topped up by informatics modules like hospital communication system with all the required alert, notification, data share, file share, but in secured model. Next, we created digital signage and automated queue. These work interrelated, targeting all the healthcare setup, starting from small health posts to big medical colleges, to government institutions, to all healthcare providers. Now, there is no need of another queuing machine. With the name, customized name of the next queue or turn of the patient, it gives information and calls the patient inside. It has been able to address the crowd management, queue management, noise management, etc. And next version or next module, which has covered our products to create a grid or network or connection system from rural to urban, urban to urban, or urban to rural, it's a grid or chain or network mechanism. And of course, like I mentioned, in healthcare ecosystem, payer is very, very important group, and Nepal government has come up with beautiful insurance plan, social security fund plan. There are different third-party payers. Our system, being a web-based technology, it can integrate all these payment system as well. And next module we have got, as per the legality of government as well, organized referral. Thus far, one rural part of community sending patient from one part, go to this part. Look, sharing location, you have to go to this part, won't be enough. Rather, it has to be bilaterally informed mechanism. We created that. And to address patient side, we created online ticketing system. It's not only online booking, it's a prepaid ticketing, and many public hospitals, private setups have been using it as crowd management tool or prepaid confirmation tool with, and it's topped up by the dashboard to the doctor's administration and patient as well. Mobile application, of course, now it's an era where mobile phone or cell phone is not a property of elite class. Even if we look at the rural community in Nepal setup, we can see many older community, many even illiterate groups carrying mobile phones in their hand. So all the records can be sent to the mobile applications they have. And next, it's only plan. We have not introduced it so far, but we have been working closely with regulators, banking system to top up our certain emergently important health component as a rider to the banking system in their already existing card. I have only few slides. It means Mediflow works as whole body, not only as an organ or tissue. That was the major problem in our healthcare setup. We all know that. It's running piecemeal, different departments working as different departments. They are not integrated. And our system, even it has got communication ability, it can be connected two ways. Mediflow securely can handshake through middleware. Server will be in the health setup, and anytime as per requirement, it can handshake safely with another channel, payment channel, hospital to hospital linkage, health post to hospital linkage, so that telemedicine also can be applied very practically real time. We have got plenty of interconnectivity. That's why it is very useful for rural health setup. Without connectivity, without real-time data exchange, telemedicine and interconnectivity won't be enough. Okay, few slides left, 3 or 4 slides. Okay, we have presented this slide a few days back to one province. It's a very rural community, Karnali province. We convince them that all the healthcare providers can be brought into a single grid with safe connectivity data exchange to the central database through provincial database. Okay, this can create national health grid with a single dashboard. Okay, I skipped this slide. We have come up with different differences. And this is the mobile application that even father, mother, if they cannot use, let's say they are illiterate, their son or daughter-in-law can serve on their behalf, or even their grandchildren can obtain the report and tell them, okay, grandmom, your blood sugar has arrived. Okay. Likewise, this is the online ticketing system we introduced to different public hospitals. This has been recently being used by the premier medical institution, medical school here in Nepal, where we can, the users are given chance to choose the department or symptoms. They'll fill up all the details in 3 to 5 minutes. We have calculated the time, and finally they'll choose the payment modality. And finally, they'll get the PDF ticket, which is prepaid. They directly go in front of doctor's chamber and they can save up to 3 hours. That's totally unproductive time for a patient. Patient means even if he's of 6 feet height, he'll go weak when he's ill or when she's ill. Okay, we have come up with different impacts through our system. Already it has been installed in more than 50 institutions. More than 2/3 are public institutions. We're able to bring the outreach center of even Dhulikhel Hospital. We're tending to do that very soon. And the Dolkha Hospital, I saw Dr. Rajkumar Dangal, he's been using this system. And my point is how it works for rural health network. First, it creates referral channel and connectivity. It creates a grid system. It serves as real-time telemedicine platform. It serves as second opinion tool, saves time, money for service takers, and it will give chance for data interpretation for optimal resource mobilization. Okay, last slide. Of course, we love to be change maker with the combination of new vision, new technology that ultimately gives new solution. Okay, we can prove together, we can grow together. Thank you very much.
Thank you, Dr. Subhas. It was an excellent presentation. Now, Andy Blyden is already in the air. It's early morning in UK, so yes. We're disturbing him in the early morning. So thank you, Andy, for your presence. So Andy Blyden works for ECH Alliance as the Director for Ecosystems and Membership, and has developed and built a large network of over 55 global digital health key ecosystems and membership community of over 750 organizations. He has had long career in both funding, health, and social care, going back over 30 years, starting in the mental health field, working with mentally disordered offenders homeless young people, and then later in the field of dementia and robotics. Andy has for the last 18 years been working in the UK and Europe with local and regional government, where he also specialized in adult social care, robotics, telehealth and telemedicine, economic development, regeneration and dementia. He also built and formed alliances with pan-European groups, most recently with the EIPA, Coral and Covenant Demographic Change, as well as with ECH Alliance with the Greater Manchester ecosystem. In addition, he has also been working as an external expert for the European Commission since 2013, assessing proposals, and in this role, now Andy leads on ECH Alliance ecosystem and membership. Andy, so please.
Good morning.
Start. Yep.
Good morning from the UK.
Good morning.
This very, very fresh and early start to the day. Hopefully you can all hear me. I'll just check my...
So you can share the screen, I think.
Yes, and I should share my screen as well. So, okay, let me share my screen. What I'm going to talk to you today about is a concept we've developed called the Global Connector. And we see that as a methodology for digital health, which during current times has become more currency and useful, not just across Europe, but across the globe. And what I'll do is talk about who we are, what we are, and where we are, and also what it means to be a member organization. And I should talk about what has just been talked about, this concept of our ecosystem network and what value it can bring in terms of maybe looking at some of the ways in which we can connect up the dots, but also look at the specific areas around digital skills and rural and remote care. So in terms of who we are, I can give you a quick idea, but the concept is with a global connector, we act as the point in which all the dots in digital health care and social care are connected through a number of organizations and ecosystems across the globe. We have 750 member organizations who are members of us, and a wide network of 16,500 people who are all digital health and social care professionals. Okay, we're a not-for-profit organization with bases in Ireland, in Europe, and in the UK, where I'm based here. We also have developed a series of digital health ecosystems across the globe, ranging from Argentina to Australia, from Finland to Sri Lanka and India. What that gives us, we think, is an intelligence network tool whereby people can physically, in better times, meet and collaborate. But obviously at the moment, as we are today, and this is a wonderful opportunity, to be able to do this online and come together, learn and share. Our organisation seeks to, as I said right at the beginning, connect up the dots. We've also created this network of ecosystems, but we provide a number of other functions which you can see in front of you. And people join us because of the following reasons. But obviously, most of the organisations that join us because they want to connect with each other and work and collaborate together. And that's why we're here today, for collaboration reasons and to learn more. One of the things that's very interesting for us to get across is most of our organisations that join us for free because they're not-for-profit organisations, government bodies, academic and research institutions. Not the best business model in terms of income, but vital because it's important for those organisations to meet, collaborate and connect. As an example of that, some of our organisations that are members are departments of health, regional ministries, you can see in front of you, from a wide variety of different countries. And that's growing as our networks grow, including Latin America and India and Sri Lanka. We've also got organisations such as the Commonwealth Centre for Digital Health, who we partner with and work very closely with in a number of countries and regions. We've also got a very large number of hospitals that are members of us because they want to collaborate and learn from best practice. These give a vital link between the hospital health side, but also our companies who are members of us as well. What that does do is link up hospitals, companies, academic organisations, regional ministries with those vital key ingredients that are usually missing from member organisations, which are patient groups. We, right from the beginning, have sought to involve patients in our ecosystems and citizens in our ecosystems because they should be central to all health and social care. Our ecosystem networks bring together all of those players, not just one. It's not a talking shop necessarily targeting academics or health professionals or companies, but leads with a need. So by combining those together, whether it's the World Federation for Incontinence or the small businesses based in Estonian country, or the NHS groups in London, these bring all the voices together in what we have developed, which are a series of ecosystems. These are permanent, multi-stakeholder gatherings that are geographically based, but as you can see on the diagram in front of you, contain all the stakeholders we believe are vital within a health ecosystem. Now, I joined the first ecosystem when I used to work in social care and healthcare. I joined because I wanted to meet innovators, procurers, and funders. My role then was around social care and dementia, but I was running programs in quite rural areas around robotics and also health literacy. We see ecosystems as coming with a vital role, which is to break down silos that exist in health and social care, where people don't talk to each other or share information. The bad news is that despite digital technology, those silos are getting deeper and wider. And I say that from someone who joined, as my colleague just said, and started work in 1990. Our ecosystems also are there to break down silos, but also transform healthcare and social care. Not just a talking shop, they actually do something. We bring these together on themes. It might be dementia or diabetes or rural care or frailty or falls prevention. And the goal is to actually bring need and solution together. So we listen in our ecosystems to what the need is in the local region. What's the need for the patient? What's the need for the social care professional? But also, what does good look like in the region? What does good look like nationally in terms of good practice? And vitally, because we're an international network, we bring in good practice from other ecosystems, often quite difficult and challenging in some regions, because we suffer as a globe from not invented here syndrome, and we won't see the benefit from other solutions. So we use our ecosystems to try and challenge that. Lastly, our ecosystems are there because we spend, by and large, the largest amount of our money on health and social care, especially during these times. We believe that health offers great economic opportunities. So we also include small companies and large companies in that ecosystem. Now, that's quite a challenge in some countries to begin with, but people get the concept now because this is where the innovation happens, and this is where a lot of service provision is being created. And you would have seen all that already this morning. All our ecosystems are different, but there's some things that tie them all together. They should be free to attend. If you want the involvement of the voluntary sector, you cannot charge them to turn up. But lastly, they must lead with a need. If it starts with the solution first, you're not listening, you're talking. And the idea about connecting up the dots between all those stakeholders is glued together because patients are at the centre. Now then, our ecosystems spread quite widely across the globe. As I said, we've got ecosystems in Argentina and Australia. We have large concentrations in other countries too, such as Finland or Spain, or in the UK and Germany. We're starting now to build our ecosystems in Sri Lanka. We're about to develop and open our latest one in India, in spring 2021. The other thing we're concentrating on in 2021 is something we've been working on for quite some time, which is our Global Connector Partnership, which is joining up with our partners globally to see where we can have maximum impact. So we've been working quite closely with the Commonwealth Centre for Digital Health and colleagues in Africa to look at targeting our first ecosystems in Africa too. Now, this is where I was keen to come along today, because I think the potential to open up ecosystems is much further than that. Many of our ecosystems are small, rural and remote, or thematically based within a region. And I think that offers a lot of potential for colleagues here today, which is why I decided to accept the kind offer to come along. What that means is our Global Connector Partnership helps them bring in a network offer whereby existing clusters or networks can join us for the following reasons. They become part of the network because they want to collaborate, because they want to bring in best practice, they want to scale up innovation, but also increase access to international markets. The last and most important thing we'll be looking to do in 2021 is develop, build and roll out a series of thematic innovation ecosystems, which then, instead of working vertically on the geographical setting in terms of a country, only work horizontally across country. And these will be built on a number of themes, one of which, listening to the previous speaker, one of which will be quite exciting because it will be built around digital health and well-being. I will include the topic of digital inclusion, which is a very, very important area of concern for many of our ecosystems. The second topic we'll be covering will be around mental health and isolation, often seen as what will be the next wave that comes along with the pandemic globally. We shall also be looking at the area of digital skills, life sciences, and also, we hope, around interoperability and integrated care. But we'll share more of those details as they're announced. And we'd welcome involvement, because that horizontal approach means that people can become included and share best practice. What that means practically is I can bring together the best practice, and I wanted to talk today about and focus on digital skills, digital health skills, from countries like Scotland, who've got exciting, ready-built packages to train health and social care professionals that could be rolled up and scaled out to other countries and shared across resources across our wide network. What that means is we've got people who are really leading the way, not just across Europe, but across the globe in delivering digital skills training for health professionals and social care professionals in ways that can be shared and rolled out and targeted within other countries easily, so people don't have to reinvent the wheel. That combination, we think, has got the offer then, not just with us in Europe, but with our colleagues in Latin America, in India, Africa and the Commonwealth, but also with the US, where we've got strong connections with the American Telehealth Association and Health. Our connections with the Africa Health business organisations in Africa and the Commonwealth Centre for Digital Health also mean that we can then connect up in countries such as India, and we hope countries such as Bhutan, Nepal and Pakistan, to extend the reach. We've made connections through those already with colleagues in Malaysia and beyond. And we think we would love to be able to find out more about how we can help and collaborate with you. So I'm going to stop talking now, not just because it's very early o'clock in the morning here in the UK and everyone else in my house is asleep, but I'm interested to listen to you and some of your questions. That's enough from me. If you want to contact me, I can share these slides via the organisers for free. My email and contact details are there. You can connect with me via LinkedIn. But I'd like to use, if I can, any chance now if we've got any questions from colleagues.
Okay, thank you, Andy. So now I think the session is open for discussion. If anyone has query, questions, suggestions, please. Is there any question to anyone, to Andy or Dr. Idris, Dr. Fadila? So my question to Dr. Fadila, because you are connecting so many islands there, and you must have gone through many challenges connecting, challenges in technology. So what were the main issues, main challenges that you faced during your program?
Okay, thank you, Dr. Udaya. The main challenge, I think, is the geography. So it means that actually, ideally, we try to connect all the islands with fiber optic technology, but it's impossible in our case because, as I mentioned, we have more than 17,000 islands. So geographically, challenge is the most difficult thing to solve in Indonesia. And the second one is about the financial viability. So there is no, for example, the private sector want to invest there because the population, total population is not, when they calculate the financial business case, they cannot have the return, for example, for 15 years. So that's why government have to chip in and make some contribution and subsidize to develop that area, and we call it a treaty, very remote area, very outermost and very least developed regions. Thank you.
Thank you. So maybe Andy has this solution. He wants to make it accessible and free for all. So what is your plan? How will you make it free for all? Andy?
When we talked about being free, the concept we talk about of involving people who are usually excluded from health and social care decision making is that they can then take part. So it's free to access. Membership of organizations like us is quite commonly free because obviously large companies would be seen to perhaps pay some sponsorship. But involvement must be free for patients and citizens. And I'll give you an example, just one example if I may. We used to, in many of our ecosystems, focus on the area around dementia, okay? Now it's important there to understand the need from the side of the patient, the carer, the family. For them to turn up to an event is already going to cost them time, money, possibly a great deal of extra moving around of their resources, because there's a caring responsibility. So if I want to find out what it's like for someone who's just received a diagnosis of dementia, what do they need? What information do they have? But also, we're human beings. What does it feel like? So that health and social care professionals understand what it's like, what their needs are. I need to make that free. But also, to understand what information and resources their family need is vital. Because otherwise, we're creating services and information in the dark. Now, if we charge people to turn up, if we make it really, hard, they've already got a caring responsibility. And if you've been involved with the care of people who are living with dementia, that's 24 hours a day, 7 days a week. That's kind of pretty full time. To get additional support when you're caring for someone who is there next to you most of the day is hard. So let's not make another burden. By making it free to take part and to listen, you're more likely to get people to engage. You're more likely to hear the need. And vitally, if you're making solutions, you're more likely not to develop solutions that people don't want. So we've seen a plethora, a large amount of devices developed, robots that don't work, touchscreens that people won't use for people living with dementia. That's wasted innovation because people wouldn't listen.
Thank you. Thank you. Yeah, Dr. Idris.
Thank you very much. I think these are very important questions that have been raised, and I have the benefit, first of all, to had conversations with Dr. Fadila, but also attending your previous APAN50 event. And in regards to the question that Dr. Fadila was answering, I think there are two issues here. One is technology, and the other one is funding model. The presentation by Professor Jun Murai alluded to the low Earth orbit, LEO satellites. And these satellites are have become a lot more cheaper to launch. And then now there are a number of private companies, including one owned by Tesla or SpaceX and a few others who are launching these. But also actually governments around the region in ASEAN, like Indonesia, Philippines, Vietnam, have also been involved in launching microsatellites. And so I think this is an area to look into. But there's a potential of lowering the cost, so that the old return of investments with fixed lines in particular, or even using base tower stations, BTS through mobile, may no longer be valid, because I think depending who actually will win the race. At the moment, everybody's racing to it. But hopefully, governments can be involved. Now, with respect to funding model, I see that there's a very interesting contrast between APAN50 and APAN51, in that previously at the rural healthcare session, we had a presentation from the offsite care group that sort of alluded to the model of support from Rotary clubs and other business clubs on a voluntary basis to activities in Nepal, for example, if I recall correctly. And I think that's a fun, great initiative to have. And there are lots of Rotary clubs around in Indonesia, Philippines, Malaysia, and any other countries, or even other clubs like Lion clubs that could sponsor a particular regional hospital or a community health facility. However, I think the main responsibility still lies with the government to be able to provide healthcare, and I think Indonesia has provided a very interesting model whereby the connectivity part of it is being funded by the universal services obligation that is being paid by the telecommunications company. So USO has been around for years, maybe from the 70s, 80s. That is to trying to get, it's a mechanism, I think, that originated in the US or somewhere in the UK. The idea was that for regions that are not economical for telecommunications company to lay the lines or open up base tower stations for mobiles, that there could be some additional funding there. But I believe that this is probably with the COVID-19 pandemic, this is an area where it could be perhaps extended to cover also certain types of software, essential software, that so that, I mean, what's the use of equipment if you can't actually serve the patients, So I think, again, I mean, there's a role for government to play here. I'm sorry that I'm a little bit.
Thank you.
Just one more thing. I'm a bit critical at all free models that have not very strong privacy provision, because there is a saying in the Silicon Valley that whenever there's a free product, the user is the product origin. In other words, the information of the user will be used by the provider to be sold to third parties. And this is something that is becoming more and more apparent. And there's been a lot of discussions, like the one that I alluded to, called surveillance capitalism, a topic. Professor Ron Debert from Canada is one of the sources that you could look into for that. Thank you very much.
Thank you. Thank you. From Shankara Netralaya, Professor Sheila, are you there? Sheila, ma'am? Ibrahim? Okay.
Dr. Udaya?
Dr. Fadila? Yes, Dr. Fadila.
Yeah, I have one question for Dr. Idris Sulaiman. Based on your massive research on data protection, is there any common or standard or best practice for the governance of data protection and data sharing in health sector, Idris?
Thank you very much for the question. Well, I think there are some developments that are taking place, and I've alluded to these under the ASEAN Digital Ministers meetings at the ASEAN level. However, as most people know, that the gold standard for data protection is the European Union general GDPR, general data protection laws that are available in Europe. And so a lot of providers that have to deal with Europe have to comply with that, and most companies actually have to employ somebody to actually deal with compliance. So it is quite complicated. However, it is comprehensive and it's seen as the gold standard, GDPR.
Thank you.
Yeah. Okay.
Thank you. We are running out of time.
And thank you.
Yeah, thank you. Thank you very much. It was very good, interesting to have discussion. We could have more time, sorry, but the time is running out. And what I told Andy and Dr. Idris, Dr. Fadila, is that we should have hundreds of Andy, hundreds of Dr. Idris in Asia, so that we can have more use of this networking, digitalization in health, so that this healthcare delivery will improve. For that, I think we need more training, more sharing, and more structured curriculum in telehealth. So it was a nice meeting. And
before we all leave, I would like to request you all, if it's possible, can you turn on your cameras so that we can take a look at your beautiful faces and take a group picture. It's okay if it's not possible though. Thank you.
And with that, we will also say, shaking hands, say goodbye.
And please don't forget to do the survey. We've just shared it.
Thank
so
you.
we'll be sharing this in our APAN.
Thank you very much, Dr. Udaya and your team.
Thank you.
Thank you very much.
Have a great day.
Nice to meet you.
Nice to meet you.
Thank you.
Bye.
Thank you. Okay, goodbye.
Back to bed.
Thank you. Bye.